the courage, the articulation, and the positivity all of you bring. So I don't think I can say or do anything to beat the performances. And when I was hearing Sajid, no, every third sentence would say wife, wife, wife. So I was not able to understand much of what he said, but I got that he's a very loving husband. All husbands should do it. Every third sentence, keep saying wife, wife, things will get better. Right. So one is that. Second, the way he narrated the whole story and such vivid memory he has, it's extraordinary. So we were just sitting, he started from the diagnosis with the first line, the second line, and then the travel, and the conditioning therapy, and then the post-transplant recovery, and then he touched upon food. And then we're thinking, is he scolding us? So because not many like the food in India, forget all of you. Our own patients, keep shouting about the food. So one of the things we doctors think is the moment the patients and families are talking vehemently about food means they're recovering. Their strength is recovering. Now they're able to think beyond illness, which is so we're all working on it. So one of the things I think Anjana district told us that we Indians use a lot of spice in our food. So they say when a non-vegetarian food is cooked, there is less of non-vegetarian and more of spice. They say we Sri Lankans like meat and the smell of meat. So I think our team is working on that too. Now, I think she mentioned CAR T-cell therapy. I don't know if it's going to interest all of you, CAR T-cell therapy. It's going to be a very boring lecture. Maybe I should sing Lag Ja Gale. That's one of the iconic songs that she sung. So CAR T-cell therapy, we have moved, when we treat cancer, we have moved from conventional therapy. I think the doctors in the audience would appreciate. So conventional therapy is like carpet bombing, right? So there are 10 bad guys, there are 100 guys. You do not know who are those 10 bad guys, and then you carpet bomb the whole area, and then you hope and pray that the bad guys are gone and the good guys will come back. So it is similar to that. There are various protocols, there are various agents, but essentially the summary is carpet bombing. From then we have moved to more targeted therapies, for example, monoclonal antibodies, wherein there are certain antigens of the cancer and then try to target it. CD9, CD20, for example, rituximab is one of the common therapy that we use, anti-CD30 antibody drug conjugate. So that is target therapy. Now, CAR T-cell therapy is also termed as chimeric antigen receptor therapy. So essentially, when we talk about immune system, it has innate and adaptive immune system, and we have B and T cells, right? So the B cells, what they do, they have antibodies which can go and bind to a specific antigen. However, they are not cytotoxic; they can't kill. Whereas the T cells, they have cytotoxicity. They release cytokines and they can destroy. So chimera, chimera is an organism which has features of multiple ones. So chimeric antigen essentially means it has the surface binding characters of a B cell, which makes it specific, and the intracellular machinery of a T cell, which means it can kill the bad cells. So it has best of both the world. That is what is CAR T cell therapy is. It's been there in the Western world for a long time. However, for all of us developing countries, it was a distant dream because the cost of administering CAR infusion is prohibitively high for most of subcontinent patients. It runs in several crores. If Dr. Nulupilli can correct me, if my knowledge serves me well, most CAR infusions in the Western world are anywhere from 5 to 20 crores, 5 to 15 crores at least. So that is too much of a cost for most Indian patients. The two common CARs that we have presently are one is CD19 CAR, essentially used for acute lymphoblastic leukemia, diffuse large B-cell lymphoma, and several other indolent lymphomas, wherein most of these the cancer cells express CD19 and you construct CAR. So essentially what we do is once a patient has a cancer which is relapsed refractory, which cannot be treated and cured by conventional means, you do what is called as lymphocyte harvest. So all of you who have undergone transplant must remember that there is an apheresis machine. You collect cells for the hematopoietic stem cell transplantation. We collect CD34 positive hematopoietic stem cells. Here we do lymphocyte harvest, right? And then we give it to the CAR construct company, which would then genetically modify those lymphocytes and then make them target a certain antigen. So in CD19 CAR, those CARs are specifically directed at the CD19 positive cancer cells, which then has the CD19 binding capacity of a B cell and an intracellular machinery of a T cell. So conceptually, they're supposed to go and attack those bad cells and kill them and destroy them. Now, it's very easy in theory and very fancy it sounds, but in the real world, there can be various issues like cytokine release syndrome, immune-mediated neurotoxicity, some patients may develop hypertension, fever, all of that. Again, we all should make sure that we understand the whole thing. Sometimes we say transplant is curative, CAR-T is curative, but the cure is not universal. I'm sure all of you have gone through journeys which have had ups and downs and setbacks. So as human beings and as treating professionals, we should have humility to understand and accept that no one should guarantee success. It is just the dumbest thing to do. No one should try to peek into the future. Again, the dumbest thing to do. Oftentimes, patients and families come and ask us, Doctor, don't tell me the probabilities. Tell me what is going to happen to this patient or my son or my brother or my. I say, doctors should never play gods. You should never try and predict the future of how an individual patient is going to do. What we do is we have various prognostic charts, we have scoring systems, gives you the probability. If there are 100 patients treated in the past, what has happened to majority? However, how a given individual patient is going to behave in terms of tolerance of treatment, in terms of suffering toxicity, in terms of the biology of the disease, in terms of outcomes post-transplant is a complex interplay of many things, some of which we understand, some of which we don't even understand. So that is a humility that we all should have. Now, coming back to CAR-T, so we also have a CAR for myeloma called as BCMA CAR. Both of these CARs are available in India and at a much lesser price than most Western population would have to pay out. So I think the CAR construct in India would cost about 30 to 40 lakhs, and then hospitalization cost will be added. However, we only have CD19 CAR as of now. BCMA CARs are yet to be undergoing clinical trial. So CAR T-cell therapy are a newest modality of treatment for certain group of patients who have these illnesses which otherwise cannot be cured with conventional therapy. Now, we classify patients into transplant fit, MRD negative, transplant unfit, but CAR fit. So that is another population who otherwise cannot go through a transplant because transplantation involves intense conditioning. There are about 14 to 21 days of severe neutropenia wherein you are stuck in the BMT unit eating the hospital food. And sometimes I always say the person who stays with a patient, I tell them, do you even tell them jokes? Because you have to just stay in the unit, right, all the time. So it can be nerve-wracking experience. So CAR T-cell therapy is going to be changing the paradigm of treatment, at least in that section of patients who are old and frail, have illnesses which otherwise cannot be managed, and the CAR infusions are easy. And I think going forward, it will reach eventually all of you here too. So till then, whoever needs it, at least if they have CD19 and BCMA related illnesses, one can infuse the CAR. So if you guys have any questions, I can answer. I think the didactic lecture is almost killing everyone, I can see. They're just maintaining poise and sitting on the chair. Yes, it is very difficult. So any questions, then we can perhaps more interactive, we can discuss. Or you can ask her to sing another song, she's ready. Any questions? No questions? Okay then, thank you. Thank you for patient hearing and thank you for coming. I say this day belongs to all of you, not as much to doctors. It is indeed very inspiring to see all of you do so well, and it gives us more inspiration to work harder, do better, and cook better food, perhaps, next time you're here. So thank you for coming, and I can only wish you the best. Yeah.
He needs to know that once you've done perform the surgery, and there is a chance that you will do it again.
Yeah.
Why is that?
Yeah, so it's a fair question. So first of all, everybody thinks transplantation is surgery. It is not. So remember, bone marrow transplantation, also called as hematopoietic stem cell transplantation, also called as blood and bone marrow transplantation, is not a surgery. There is no surgery. Sajid can come and explain again. So there is no surgical procedure involved. So bone marrow transplantation, what we do is collect cells. It was termed bone marrow because when the procedure started previously, they would collect stem cells from the bone marrow. However, in most transplants, more so in hematological malignancies, we now collect what are called as GCSF mobilized peripherally harvested stem cells. So it is a misnomer. So it is hematopoietic stem cell transplantation. So coming to this question, do we need to do the transplant again? There are various instances. But one of the initial challenges of transplantation is, though we take all the care to do the matching, collect the cells in the number that we need, also prepare the recipient by giving conditioning therapy, which is both myeloablative, meaning making the space for the stem cells, and immunoablative, making suppress the host immune system to facilitate engraftment. Despite all that, rarely one challenge is primary graft failure. The cells which are given from the donor to recipient, might fail to take up, which is a life-threatening complication because already the patient would have received conditioning therapy. That means if the graft is not taken up, you will have prolonged, protracted neutropenia, which means the risk of complications of infection can be life-threatening. So when there is a primary graft failure, you may have to do a second transplant then and there. So that is one clinical instance. Second is a secondary graft failure, meaning the graft takes up and then the patient loses graft. As we assess the graft by chimerism, all of you know about chimerism, right? I keep receiving the reports, chimerism. So if there is a secondary graft failure, we have two ways. One, we can do a donor lymphocyte infusion, or in some rare instances where the graft fails real quick, we'll have to do a second transplant. The third issue is the patient is in remission for several years, but the cancer comes back again. And then, you decide, depending on what was the duration of remission, how fit or unfit the patient is, to decide to do another transplant. So these are the common clinical scenarios where one may need more than one transplant.
மேலதிக செய்திகளுக்காக எமது யூடியூப் தளத்தை சப்ஸ்கிரைப் செய்யுங்கள்.